It gives me great pleasure from South Zone to conduct this very interesting topic, which is close to my heart: artificial intelligence and robotic surgery. I welcome Professor Andrew sir for this lecture. Professor Palnivelu sir, founder president, the master of laparoscopy and robotic surgery in India, who is a father of laparoscopy in India and taught so many people. And I request Dr. President sir, Dr. Varghese sir to take over, and then I'll come back again.
Thanks, Jagdish. And once again, we welcome all of you for the online CME program conducted by Association of Minimal Access Surgeons of India, AMASI. And we conduct this CME program the first Thursday of every month. And this time we have a very interesting topic, that robotic surgery and artificial intelligence. And it's going to be delivered by one of the world authority on this, Professor Andrew Sams from France. And in fact, we all are very eager to listen to the talk and waiting for the talk. And then the session is going to be moderated by Dr. Biju Patakar. He's the surgical gastroenterologist at JIPMER, Pondicherry in India. And the convener of the program is Dr. Jagdish from American Institute of Oncology at Hyderabad. He is the vice president of South Zone. AMASI has 5 zones, and each zone do the program on a rotation basis. And this CME program is supported by Merrill Endosurgery, and we thank them for their support. And also, I take this opportunity to acknowledge the presence of our founder president, Palnivelu sir, past president, Dr. Tamana, Dr. Philip Gode, and Dr. Jugendra, and many other, our esteemed EC members, and also our friends from Sri Lanka, the Sri Lankan Association of Minimal Access and Digital Surgeons. The president, Dr. Bhavanta, is supposed to be here, and the secretaries, Dr. Mindra and Dr. Udaya is supposed to be here, and friends from Bangladesh, from Nepal and other neighboring countries, and the senior members from in India and abroad, and postgraduates. I welcome all of you. AMASI is now, as Palnivelu sir said, that we are back with a lot of academic activities after the period of COVID, and to be updated and on this academic calendar, please be a member of AMASI, because then only we know what's happening on the academic side. And also request you to be a member of the AMASI so that you can have other professional advancement, and also encourage your friends, also colleagues, also to be a part of this great association. With these words, I again hand over to Dr. Jagdish. Before that, I request Palnivelu sir to say a few words. I think, sir, you are muted, sir.
Thanks, President Varghese, Jagdish, at Baiju, and Tamanas and Gowns. I today delighted to participate in this meeting because my friend Andrew Gums is going to talk on the subject which is the most vital today. And he is the pioneer in this specialty, and running so much done and academically. And in fact, he's running a journal which is very popular now. And globally, he has got a very good faculty part of this. So I think Indian people also should take part. And want to time something like it today, I could not. So welcome, Andrew, and we are part of this. And so taking my time, and delighted. And thanks, Varghese. Go ahead.
So I can't thank you enough for this invitation to AMASI. This is, I think, as we talked about a little earlier, I think my second time presenting.
Can you give me a second, sir?
Oh, I'm sorry.
Yeah,
Sure.
sorry. Dr. Biju sir is a moderator. I request Dr. Biju sir to take over the session. He'll be coordinating with Dr. Andrew, and then we'll come at the end. Thank you so much.
Yeah, Dr. Andrew, you can proceed, and I will collect the questions and forward to you after your talk. Please proceed. Yeah.
Okay. So I just want to thank Dr. Podakat for this invitation, And as I was saying, it's a pleasure to be talking to Amasi again. Dr. Palanivelu, definitely one of my surgical heroes. He is actually our regional editor for the journal Artificial Intelligence Surgery. He's the region of Asia and in Australia and New Zealand, that whole region there. The other regional editors are Michel Gagne of the Americas and Dr. Michela Michelotti of Europe and Africa. So I'm going to talk about artificial intelligence in HPB surgery. I'm currently at a hospital in West Paris called it's a hospital in Poissy. If anybody of you know Abe Fingerhut, it's his old hospital. I have an academic appointment at the University of Magdeburg in East Germany, about 1 hour west of Berlin. That's where I do a lot of my artificial intelligence research. They recently got a $27 million grant from the government. So they're trying to create a technical center. So if any of you are interested in technology, I recommend contacting my friend, the chairman of surgery there, Dr. Roland Kroner. Things are really starting to get exciting over there. So what am I going to talk about today? I'm going to talk about the new journal, our new journal, Artificial Intelligence Surgery, where we just released volume 3. It's published every 3 months, and we'll talk about that a little bit later. But we're also going to talk about some definitions of this evolving field of artificial intelligence surgery. We're going to talk about what the difference between artificial intelligence in surgery is and how that's different from artificial intelligence surgery, okay? Artificial intelligence in surgery are algorithms used to help radiologists make diagnoses before surgery, algorithms that are used to help predict complications sooner than we can. And that's different from artificial intelligence surgery, which is what happens in the operating room. Autonomous actions, what actually helps us as surgeons, as people who do interventions in and during an actual operation. So what is another way of thinking about artificial intelligence surgery? It's autonomous actions. We're going to talk about all these definitions a little bit more. And we're going to talk about problems with the current definition of robotic surgery and what is robotic surgery. And to really understand that, we have to talk about the difference between weak artificial intelligence and strong artificial intelligence. And to understand that, we need to understand what are the 6 levels of autonomy. These are the 6 levels of autonomy that are based on autonomously driving cars. Okay, so it's going to be a stepwise fashion for us to get to more autonomous surgery. It's not going to be like one day the human is doing it, and then the next day the robot is doing everything. There's many little steps in between that we're going to have to do over the next several, years to decades before we get to there. And then we need to discuss whether we ever even want a future like that. But it'll be a little more clear a little bit later. And I'm going to try to show you what examples of artificial intelligence or autonomous actions already exist in interventional fields. Okay. So first off, this slide is a little old, as you can see, but surgery in 2023, what is it? It's really a mixture of open surgery, minimally invasive surgery, such as laparoscopic and robotic assisted, but it's also interventional endoscopy. It's also NOTES, natural orifice transluminal endoscopic surgery. And it's also things like interventional radiology, interventional cardiology, and the like. Anything that involves a procedure nowadays, as far as I'm concerned, is considered surgery. I just use the word surgery as an umbrella because really to split these things up is a little bit foolish. As you know, many people now, they do surgery, they do endoscopy, and they do interventional radiology procedures. That's very true here in France, where HPB departments, they have people in the same department who do all 3 things. They have some people that know how to do all 3. So I think that's really important to think that the future of surgery is changing. A lot of older surgeons get very upset when I say that. That's more of a problem in Europe. They become very protective of their concept of surgery. But personally, so you understand, when I say surgery, I'm talking about all of these aspects, all of these fields. So this is the journal. You can go to the website. It's aisjournal.net. The first issue came out December 2021. just over a year and 4 or 5 months ago. It comes out quarterly. And actually the 5th issue, this slide's a little bit old, but the 5th issue just came out, volume 3, issue 1. Right now we have an estimated impact factor of about 2.2. We're less than 2 years since we started publishing articles, so we don't have an official impact factor, but according to our citations, we're already up to 2.2. So we're already very excited about that. And we hope to have an official impact factor by around this time next year. We're gonna submit in December. It's an open access journal. If you contact me directly, your articles will be published for free. So I think it's a great opportunity to publish in this journal now. If you have anything on artificial intelligence surgery that you're doing research on, we encourage review articles on artificial intelligence. Those are very helpful for us and very interesting, and a good time to do those also. So this is just a picture of the website that you can go to. So artificial intelligence surgery, this is a hype cycle. This is a hype cycle called, anybody have a question? No? Okay. This is the Geithner hype cycle. They use this in business to talk about trends as far as stocks and industry changes, so they can try to predict things. And it has been applied also to artificial intelligence surgery. So this just gives you an idea of what this looks like. So this is helpful for us to think about the evolution of artificial intelligence surgery. Really, the first time that a screen was put between a patient and a human was with endoscopy. Okay, so that's why I put it there first. Then from endoscopy, of course, we got laparoscopy. Then we got robotic surgery. We got note surgery, and people were very excited. About, I would say 15, 20 years ago, that the robot's going to fix everything, that our life is going to be wonderful, and the evolution and innovation is just going to keep coming. As we know, that didn't really happen, and that was really what we call the peak of inflated expectations. And the enthusiasm kind of dipped, if you will. And we really hit what's called the trough of disillusionment. But at the same time, the computer scientists were developing artificial intelligence. They were developing things like machine learning, which are essentially algorithms that are able to solve problems that they weren't necessarily programmed to do so. Deep learning, which is an architecture based on the human cortex and the neurological system with many different layers of decision-making, so that they could come up with even more complex answers to even more complex problems. Natural language processing, which enables the computer to understand what we're saying and understand what is being written, okay? So it's not very easy for the computer to understand nuance, sarcasm, things that are actually complex to understand. So there's a whole field called natural language processing, which is a field that has been developed, and you use it on your phone. Every time you speak into your phone and you dictate and it understands what you're saying, that's an example of natural language processing. So there's a lot of artificial intelligence on your phone that's being used all the time. And computer vision was also being developed with the help of deep learning. And that is essentially when the computer is able to interpret images and understand what it's seeing. So at the same time as all these innovations came, we hit the trough of disillusionment. And I was asked, hey, would you like to be an editor-in-chief of a new journal called Intelligent Surgery? I thought about it and I said, look, if I can call it artificial intelligence surgery, I'm interested in it. And I had a discussion with my other friends in the field, and they're like, are we crazy to call the journal artificial intelligence surgery? At the time, we thought we were a little bit crazy, but lo and behold, our timing couldn't have been better, because as you all know now, artificial intelligence surgery has really taken off. It's really blown up around the world. And I realized that we're actually have many more autonomous actions already in healthcare, even in the operating room, that we didn't really notice. So I actually believe that we're closer to the slope of enlightenment and closer to the plateau of productivity, where there's really going to be some innovation on the horizon and coming out for us. And hopefully at the end of my talk, you'll agree with me. So just to get a better idea of some terms that are used in artificial intelligence really encompasses all of these concepts. Machine learning, some examples of machine learning are supervised learning, and unsupervised learning. Supervised learning is kind of you're telling the computer or the algorithm what to look at. Unsupervised learning, it's learning a little bit on its own. It's not as controlled. Reinforcement learning is a way that the computer learns from trial and error. That is going to be very important in autonomous actions, where the computer is able to learn from its mistakes, much like humans do. So many of the things with artificial intelligence are based on how humans interpret data, new information, and learn things. So deep learning is within machine learning, as you can see here. Again, it's an architecture. It's a structure of the algorithm. As I said, is very similar to the neurological system. You have things like artificial neural networks, convolutional neural networks, and recurrent neural networks. Computer vision here, you can see that has things like object detection, classification, segmentation, instrument priors, where the robotic instruments are in space. That's an example of computer vision, and motion analysis, and robotics, automation, and artificial intelligence surgery. So as you can see, following the hype cycle, when you put into PubMed artificial intelligence and surgery, the publications followed the hype cycle, all right? Around 2013, there was really the peak of expectations. Around 2017 here, you can see we hit the trough of disillusionment. And as you can see, as of 2021, you know, the sky's the limit. And if I showed you 2022, it would be even higher. The publications are really exploding, and we're surprised by the amount of submissions that we're getting to our journal. And we're not getting submissions only from doctors. We're getting submissions from computer scientists, from epidemiologists, you know, orthopedic surgeons, breast surgeons, gynecologists, urologists. Everyone is excited about this field. So we talked a little bit about artificial intelligence in surgery. So as opposed to other fields in medicine, we do interventions. So we have this other element that artificial intelligence can help us with. Nonetheless, we also have traditional artificial intelligence, like artificial intelligence in surgery. So there's many articles that have been published already in the journal. Here's one review of artificial intelligence for decision support in surgical oncology. We're able to tell what patients need surgery, need chemotherapy, what chemotherapy, whether they need immunotherapy, and we're able to decide better than just doing a simple tumor board. So this is a wonderful adjunct to have in your tumor board with you. You can have the computer tell you or agree with you or give you some treatment algorithms that maybe you wouldn't have thought of. And there have been some nice examples in the news of people actually having incredible results with decisions that were made by the computer that weren't necessarily made by just the humans. Of course, it's important to have a human, a team there to validate what the computer comes up with, but this is a wonderful tool and assistant for us that already exists. So here's another example of a paper talking about this from Daniel Hashimoto's group. He has a big research group in AI. He's now at the University of Pennsylvania. He used to be at Harvard. He's an exciting person to keep an eye out for. He's been publishing quite a lot of nice papers on the topic. Again, he's more interested in artificial intelligence in surgery as opposed to autonomous actions. Here's just some images from his slide. And again, you can see that computer vision with enhanced visualization and perception is a very, very big thing that's being done in the operating room. Machine learning for risk stratification and decision support. And lastly, natural language processing so that we can get good data, because as we all know, we don't have time to obtain good data to actually feed the computer, to feed the algorithm so we can actually learn some important data. We simply don't have the time. I often wonder if one day we're going to have on each surgery department a data scientist just to get us clean, real data that the computer can actually analyze to get a real answer. And I wonder if we need a computer scientist in every department of surgery, or at the very least, a surgeon with expertise, maybe a master's in artificial intelligence, or maybe a PhD in artificial intelligence, because these issues are becoming more and more complex. So here's just some other examples of artificial intelligence in surgery. Again, you can see there's using machine learning to look at postoperative complications after liver, pancreatic, and colorectal surgery. natural language processing to develop a clinical registry for IPMNs, automated pancreatic cyst screening, again, using natural language processing. Just from what you're writing in the chart, the computer will go through it and it'll populate these data sets, essentially these Excel charts automatically. So this is, as you can imagine, very difficult to do. Nonetheless, they're able to do this specifically for pancreatic cyst surveillance. They're able to get out words like the size of the cyst, whether they're intramural nodules, whether there's contrast enhancement or what have you, or whether there's a change in size. They're able to do this autonomously. Think of all those patients who have had scans for years and have maybe missed a scan, or you go back and like, oh my goodness, it talked about this, a year ago. It talked about this 2 years ago, but it wasn't picked up. Natural language processing can fix and pick up all of those. So some other ones, as you can see, looking at computer vision to automatically locate critical events in surgical videos. We're going to show a video about that, looking at the critical view during laparoscopic cholecystectomy, and the list goes on. I won't bore you with all of them. So here's an example of computer vision during HBB surgery. This is specifically for liver surgery. So this is an example of augmented reality. You're looking at reality, but you have augmented reality. You have images put onto a reality, as opposed to virtual reality, which is just something that you would see in a simulator where there's no real images with superimposed images on top. So it's important to understand the difference between augmented reality and virtual reality. Okay, so this again is an example of augmented reality. This is very difficult to do because tissue in the human body is flexible and is pliable. Augmented reality is very useful in orthopedics with structures that don't move, that aren't malleable, bones, obviously. So for us in our field, where we deal with soft tissues, computer vision and augmented reality, I think is going to be very, very difficult. It'll come one day, but right now I'm personally more interested in things like indocyanine, fluorescence dye, where it's, in my opinion, though this is debatable, it's a form of augmented reality because you're augmenting what we can see. And I think you get a much more specific image, unlike augmented reality. Augmented reality is off by a few millimeters. We all know, as surgeons who do dissections around large vessels, if you're off by even a millimeter, it can be catastrophic. So I personally think augmented reality is much less interesting right now to me. I'm more interested in other things. I'll leave it at that. So here's just an example of image-guided robotic liver surgery. Again, the images are beautiful, but you can't move the liver at all. So again, not very useful to me. Hopefully one day it will be useful, but right now no one has solved the problem yet of moving the liver or moving the pancreas or moving really anything. So I think it might be more helpful in things like percutaneous ablations or needle biopsies or something like that. But it's going to have to be coordinated with movements of the heart and lung, much like the CyberKnife does when it gives radiation treatments. So that already exists. The CyberKnife has been around since 1994. So I think simpler procedures, not in the actual operating room, but needle procedures, augmented reality could be very nice. So this is another example in the operating room with and that's an example down here of virtual reality because there's no real image in that image. Here is an example of the actual real image, and there's no augmented reality on that. So again, that's a bit of a confusing term, so I'd just like to repeat it for people. Okay, so another example of computer vision that you can get on your iPhone already, okay? This is a program called Jarvis. Now, anyone who's a Marvel Comics fan, I'm American, so I am a Marvel Comics fan. So Jarvis stands for Just Another Rather Very Intelligent System. It was coined by Iron Man. It was named after his family's loyal butler. Ultimately, Jarvis became Vision, okay? That's the character that you see there. And I just put that all there so you remember it, because if you go onto the Apple application site for the low price of $49.99, you can already buy this program, okay? The Surgeon's Jarvis. So imagine you're a young surgeon, it's 2 a.m, you're doing a gangrenous gallbladder, you're having a hard time finding the critical view, you don't want to wake up your senior surgeon. As you can see here, as these red lines on the bottom go from red to green, it'll tell you that you're meeting the criteria for the critical view.
I think picture has become fixed. Maril, and a technical side has to look at.
Oh, I think I just lost everybody. Everybody back?
Yeah, please proceed. Yeah, please proceed.
Okay. So I was just saying, again, imagine if you have an injury and you don't have this, you didn't document that you did this, but some people are doing studies for this. And again, I'm not sure how useful it is. Unfortunately, I think at this stage, it's something that can only, excuse my French, bite a surgeon in the ass right now, but it's important that you know that computer vision is already available. Okay. So this is the article that we published in the journal about what is artificial intelligence surgery. It talks about a lot of the issues that we discussed so far. Let me just make this a little bit bigger. Okay. Now, the reason I wrote this article and the reason they asked me to become editor-in-chief is they asked me earlier to write, to be an editor for a special issue on what is robotic surgery. Now, robotics is a bit of a misnomer. The word robot comes from the Czech word robo, which means slave. So I always tell people that the robotic surgery that we do today, it's not a true robot, it's not a true slave, because the slave is still us. We're the ones doing all of the work, okay? There is no robot who's actually working. We're telemanipulating. So that'll make a little bit more sense once we talk about the 6 levels of autonomy. So broadly, before we get to the 6 levels, the concept of weak artificial intelligence are just automatic actions. You hit a button, the stapler fires, it doesn't think, it doesn't have a sensor, it fires. That's an automatic action. That's a weak example. Autonomous is where an actual decision is being made. There's a sensor, there's being information that is interpreted, and it's changing the response based on that information, okay? So I just use this as an example. This is just a telemanipulator for endoscopy. And I'm like, is this artificial intelligence? Is this robotic? No, it's not. Because as I said, it's just a telemanipulator. All right. So the 6 levels of surgical autonomy. Level 0 designates no autonomy. Level 1, oops, sorry about that. Level 1 is telemanipulation of a robot. Very low level autonomy, essentially the lowest level. So what is level 2? Level 2 corresponds to limited autonomous action. I'll show you an example of that we already have in the operating room. Level 3 is conditional autonomy, where the surgeon selects from several buttons, basically, several options that it can choose from. And we have an example of that. Level 4 is autonomous action, includes automated medical decision-making, but still under a doctor's control. There's an example of that. And believe it or not, there's an example of level 5, full autonomy, where there's no human control necessarily to diagnose and save a patient's life, okay? So level 2, this is the Signia stapler. I should mention I have no financial agreement with Medtronic, but I am a consultant for Moon Surgical, which we're gonna talk about a little bit later in the talk. So the Signia stapler, it has a sensor. When the tissue's too thick, it slows down. When the tissue's too thick that it can't staple, it won't fire. And when it's not thick enough, it won't fire. So this is an example of level 2 autonomy. There's a sensor, it interprets information, and it does something, and it changes its mind. As opposed to Ethicon straight stapler is just automatic. It has no sensor. You hit a button, it fires. So I know Ethicon, I think they have a smart circular stapler, and Medtronic don't have a smart circular stapler, but it's important to understand that there's a difference, okay? And there's probably it's probably better to have a smart stapler than it is just to have an automatic stapler. So what about the Da Vinci? As we talked about, the Da Vinci is level 1 autonomy, but the Trumpf Medical, they made a table that when you change the angle of the table, all 4 robotic arms move autonomously with you. Now that is a wonderful innovation, and that's personally what impresses me the most about Da Vinci is the table, because it's a pain in the you-know-what. Every time you want to change the angle, you have to remove all 4 robotic arms. You got to put it in. So a lot of surgeons just deal with suboptimal angles, or it just gets frustrating. It prolongs the operation. So the Trumpf Medical table is more impressive to me, and I repeat, than the Da Vinci, as far as an artificial intelligence surgeon, okay? So what about level 3 autonomy? The ligature device. This thing has been around, maybe someone can tell me, but I started operating in the 90s, but I think it's been around since the 80s and maybe even earlier than that. It's initially made from Valley Lab. It has an advanced vessel sealing algorithm. This device seals vessels. This is a very complex device. It decides when the vessel is sealed. It analyzes 434,000 data points per second to determine when a blood vessel can be cut, when it's sealed. All right, so this is a perfect example. It has 3 buttons. Depending on whether you have a large vessel or a small vessel, you have different options. So that's an example of level 3 autonomy. So I love to use this example to show that we are all already artificial intelligence surgeons. We just didn't realize the definitions, okay? So what about level 4? Cardiologist, there's a patient with an arrhythmia. They will access the vessels. They'll snake up the catheters into the right atrium. And then from that point on, the device will detect an area of an arrhythmia, and essentially the robot will do the ablation autonomously. You see the cardiologist, just chatting while this device does the ablation autonomously. So that's a perfect example of level 4 autonomy that already exists. So now, can anyone tell me, is there an example of level 5 autonomy in healthcare? Can anybody think of a device that works completely independently from human control, that can diagnose a life-threatening injury and give a life-saving treatment? I'm going to let you suffer for a few more seconds thinking about it, because there's an example that's been around for over 20 years. I'm going to go to the next slide.
I think it's pacemaker, huh?
That's exactly what I think you've seen my talk before, but it's the AICD, the automated implantable cardioverter defibrillator, right? A pacemaker is arguably also, because it keeps you in rhythm. That could be another example, but I like to use this one because literally it'll detect a malignant arrhythmia and it'll give a life-saving shock, and there's no human involvement whatsoever. So people talk about regulation, autonomy. I just had a meeting with the FDA 2 days ago about the autonomously, the scope that will follow the surgeon's instrument. And they're like, oh, this is new technology. We don't know. You're gonna have to do a de novo process. It's gonna be prolonged things. But it's not true. There has been examples of autonomy, for a long time now. It's just that we also, as surgeons, are part of the problems. We didn't realize it, and we don't know the definitions of this. And we need people who are experts, more experts in technology, more experience in engineering and artificial intelligence. So because of all these issues, we wrote a paper, the white paper with definitions of artificial intelligence and autonomous actions in clinical surgery. It was written by the editorial board members. I encourage you to go read it. It'll talk more specifically about the different levels of autonomy. If you're interested, it explains everything that I just talked about. So also we should talk about the 4 classes of medical devices based on risk, okay? Interestingly, so the higher the risk, the higher the class in general, okay? So these are the United States definitions. Class 1 are things that have minimal risk to the patient and remain in limited contact with the patient. So believe it or not, surgical instruments are class 1. Class 2 are things like CT scanners and contact lenses because they remain in contact with the patient for a longer period of time. Class 3 things are things like hemodialysis and implants, like meshes and things like that. And class 4, or even, orthopedic implants. Class 4 are things like implantable defibrillators and pacemakers. So this just shows you how in Canada, Europe, and the United States, we basically have 4 classes based on risk, okay? So we really started to wonder if a 5th class should be designated for devices that make real-time clinical decisions using AI during procedures. Maybe things that are level 4 and 5 autonomy should have a higher class, should be even class 5, but maybe things that have sensors that actually makes things like staplers safer, maybe they should have a lower level so that they can be approved quicker and they can encourage and stimulate industry to give us more intelligent instruments. So maybe things that are level 2 to 3 should be class 0. So that's just depicted here. Maybe we need a class 0 and then maybe we need a class 5. Again, based on what level of autonomy, or whether it's weak artificial intelligence or strong artificial intelligence. Okay. And again, that's discussed in the white paper. So it's important to know that most current robotic systems are all just telemanipulators. If you look at them, there are about 13 on the market now. They can be grossly split up into ones with multiple arms, ones that do single port surgery, and ones that do endoluminal, all just telemanipulation. So everyone knows the Da Vinci. Everyone maybe knows the Versius, which is made by CMR in the United Kingdom. I like this device because it has 4 arms, but they're not attached like the Da Vinci. The Da Vinci arm weighs 800 pounds or kilograms. I forget. I'm going to say kilograms. Each one of these arms of the Versius only weighs 100 kilograms. So it's a much gentler robot. The Da Vinci can really rip things to shreds. This device, it's much more difficult to damage things. And also you can be more creative with where you place the robots. So I think this is a potentially a very promising device for telemanipulation. I think Da Vinci is particularly excellent in the pelvis. It's nice to have a single base. So it's important to realize the different advantages and disadvantages of each system depending on what you do and where you operate in the body. So here's Avatera. Again, looks like 4 arms. Again, it has a console. The surgeon is not attached to the patient. This is Bitrack. This is Senhance. Senhance is nice because it actually has tracking. It has tracking right now. So when you're operating, the camera will move for you. So which is a very nice feature. I've used it in the Moon surgical device. It's kind of like hitting the turbo button in the old arcades when you really want to go fast. I used it after doing the dissection on the gallbladder, after getting the critical view. When you dissect off the gallbladder from the liver bed, it's a very nice feature to use because you can do it very, very quickly, and it's a real pleasure. Senhance, I believe, is the one where you can actually remain sterile while you're operating. So I also like this device because you can go back and forth and you're remaining sterile. If you have a bleed or a problem, you can go back very quickly. So here's the Hugo system made by Medtronic. This is Dexter, which Dexter might be the one that you remain sterile in. Actually, I think I'm confusing those two. I can't remember now. So Intuitive single port, that's what that looks like. Vicarious has a single port robot. Enos has a single port robot, again at a console. Here's the Mira single port. Here's an endoluminal device made by Hominis. And then some other endoluminal ones, Ion, Monarch, and Colubris. Again, but these are just all telemanipulators. So it's a real shame to me that all these companies have been developed and they're just based on the same concept, the same way of thinking, and they're not giving us new types of robotics. And we'll talk about what type of new types of robotics are possible. So I think the easiest way, do I still have time? I think I need another about 5-10 minutes. Am I okay?
Yeah, please carry on.
Yeah, please.
Okay. So the easiest way for me to interpret where we should go in the future is, believe it or not, is to use examples of Star Trek or Star Wars. Okay. Star Trek, the surgeon is always at the bedside. They're always in contact with the patient. They're not at a console. They're not away from the patient. Okay, even in the next generation, the surgeon is always there. Now, Star Wars, there's a robot, there's no human surgeon involvement at all. There's just a patient screaming on the operating room table being operated on by these robots. So these are two very different views of the future and two very different, we're at a branching point and we need to decide, do we want to go to Star Wars or to Star Trek? Right now, Da Vinci, every time you do an operation, they're downloading all of your instrument priors, the movements that you're doing for every case. So they have all this data. Now, using deep learning, they're going to be able to create autonomous surgery. It's happening. So if we don't understand that it's happening, if we don't understand that it's possible, then industry is going to continue to dictate what products we get and where we're headed. Okay. So because of this, I wrote an article called Keeping Surgeons in the Loop. I like to do handheld robotics where I stay in contact with the patient, where I'm not at a console, where I remain sterile. So here's an example of a handheld robotic instrument where you're still in contact with the patient. Here's an example of a sterilizable small endoscope holder that fits right on the patient, voice controlled or active. The stapler, it's an example of a handheld robot, right? It has a sensor. The Da Vinci has a robot, but this is the same technology. So we have it. So what about collaborative robots? We need to understand what a collaborative robot is. That's what's being used in the industry right now. There's a lot of robots that do the entire part of a procedure to build a car, but there are also humans that are working with robots in collaboration. These are called cobots. Okay, so another example of this, I mentioned that I'm a consultant for Moon Surgical, is a new device that's going to come on the market soon called the Maestro. So people probably or may recognize Brice Gaillet. This is his brainchild. This is a robotic arm holding the camera. There's another robotic arm that holds a retractor. And then the surgeon is operating just with standard laparoscopy right in the middle. He's in. Okay, we're back. All right. So this is an important and a different way of doing robotic surgery that we need to know about and we need to support, in my opinion. Okay. So, all right, there goes that. So here's another little handheld robot I want to show you about. Here we go. All right, so this is a little handheld robot that is used for interventional radiology. You can set it up and it'll align perfectly where you need to put the needle if you want to do an ablation, if you want to do control of an endo leak for, after a AAA endovascular repair. It fits right on the table. And this is a nice little handheld robot that has a lot of advantages. Imagine now you have a patient with 7 liver metastases. You can do ablations very quickly. It'll line it right up for you. Maybe we can expand the criteria, the type of people that we can do surgery on with little robots like this. So it's important to really know what is out there. I'm not going to show the entire video, but this is a nice little product that already exists. It's been on the market for about 1.5 years right now. And I think this is the type of thing that could be very useful in the operating room for liver surgeons, okay? As you can see, it's particularly useful also for things on the spine or what have you. It gets its imaging from either a C-arm of a CT scanner or from fluoroscopy, okay? Okay. So I think in the future, a mixture is probable. We'll probably use console robotics, non-console robotics. I talked about the advantages and disadvantages, a little bit of the other robots, Da Vinci or Versio, so I won't get into that. I do think non-console and handheld robotics has an advantage for cost and for safety. And I think it's very, personally, I'm a fan of Star Trek and I want to remain in the loop. I want to remain in contact with my patient. And I think that's more interesting. And I hope that's where we're headed in the future. This just shows you what is already available as far as what we need to get to fully autonomous surgery if we ever want to get there. You know, again, that is another debate. As I said, I don't want to get there. I want more autonomy, but I still want the surgeon in the loop. So vessel sealing exists, stapled anastomotic lines exist, automatic needle placement you just saw exists, motion scaling and tremor reduction, that's things that the microsurgeons, the neurosurgeons already use. Organ segmentation, you looked at the computer vision already where it was highlighting different parts of the organ, that already exists. Laparoscope tracking already exists, actually, so I had to add that. So that exists, where the camera will just follow you wherever you're going. Autonomous aspiration is in the prototype phase. Autonomous retraction is in the prototype phase. Autonomous debridement, suturing. There's actually a robot now called the STAR robot that can do a gastrointestinal anastomosis autonomously, and it can do it better than a human can. So you also have knot tying that prototypes can do. What we don't have is situation awareness, you know, or phase recognition. What part of the operation we're in is an example of phase recognition. It's hard for the robot to have a memory. Situation awareness, is there bleeding or something? Is something else going on? That's also hard for the robot to know, but they're working on it. Autonomous pneumoperitoneum access, I'm actually working on a company with that because that's coming along the pipeline. And we already talked about autonomous dissection. Da Vinci is recording your instrument priors, so they're already working on that. You can already send your videos to these huge databases, and they're starting to interpret that and trying to work and devise algorithms for that. So this is just more of a complete Geithner hype cycle with things like radiomics, organ segmentation, augmented reality, virtual reality. I do want to mention that we need to understand the concept of DEXEMs and a surgeme. A surgeme is a part of an operation like a gastrointestinal anastomosis during a Whipple. A DEXEM would be perhaps the stapled anastomosis, and then maybe the closure with suture would be another DEXEM. 2 DEXEMs or 3 DEXEMs would equal 1 surgeme. So to get to more autonomy, people are doing part of procedures autonomously. Again, like the stapled anastomotic line, that's a DEXEM, that already exists. Again, and how we're going to get to more autonomous actions, okay? So I think current AI and HBB surgery includes machine learning to help with clinical decisions, and acquisition of data is going to be enhanced with natural language processing. I think advances in computer vision are the most exciting, you know, the most visually stimulating, but I'm not sure if they're actually going to be the most useful in the short term. And lastly, if you remember nothing else, I want you to remember that intraoperative surgery that utilizes artificial intelligence is the same as autonomous actions. Artificial intelligence surgery or autonomous actions. And I think that's the most exciting aspect for me as a surgeon. If I can have a robot enable me to do a surgery that I do now better, or maybe enable me to do something that I technically can't do to better my patient, I'm all for it and I'm very open for it. But again, it's important that we understand, you know, the potential negative effects of that. And it's important that we're in the decision-making and the development process of all of these new technologies. Thank you very much.
Thank you, Dr. Andrew. I think I'm sure the audience got an idea in depth about what exactly is the robotics and artificial intelligence and what is going to happen in the next decade. We have some questions, and before that, I need some request some clarity from you for the benefit of the wider audience. So we are looking at enhancing the visual platforms through AI. So that is probably one of the areas where a large amount of research is going on and development is going on. So in terms of deep vision to the tissues, so for example, when you do liver surgery on field, on the screen, in the monitor, you see structures inside. And you do a right hemicolectomy, for example, you see urethral vessels on the screen. What is the practical timeline for this technology to come, and will it be useful? You mentioned, I heard that it will not be so much useful as we expect, but what is the timeline we are looking at? And as surgeons, we know that we are actually not operating by direct vision. We are actually operating currently on indirect vision on monitors. So these platforms coming in monitors will be really helpful. So what is the timeline we are looking at? How useful it is?
I mean, it's a great question. And as you know, places like IRCAD have been working on for decades on augmented reality. And they've done beautiful things, amazing things. They've made incredible progress. But I've never seen a product that people are buying and actually using in the operating room in any great amounts. And it's because of the issues I mentioned, because it's, even if it's off by 1 millimeter, for us, it's essentially useless, truly, in the operating room. When you can use an ultrasound to look at a tumor inside the liver, you're going to do the ultrasound. If you can put up a lighted ureteral stent to protect your ureter, you're going to do that, because it's going to be better than augmented reality, than shooting an image down, onto tissue. It's always going to be better. Indocyanine dye that makes the tumor glow, it's just going to be better. So this is why I'm a little bit disillusioned with augmented reality right now. I think people are using it. It's very sexy, but I don't think in the next 5 to 10 years, well, I'll say 5. I don't think in the next 5 years, it's really going to have a big impact. And I'm personally more interested in indocyanine, in fluorescent dye, and so-called biophotonics. I think that's a more interesting field as far as computer vision is concerned in the operating room. Where I like computer vision is in the ability to interpret images and tell me information about that tumor that I wouldn't have otherwise. They're able to use computer vision now to tell, look at a tumor, look at a single slice, and they're able to tell this liver tumor is going to recur in less than 2 years, or it's going to recur in more than 2 years, just by analyzing the data of a single image. So imagine how much predictive data we can get. That is exciting to me, as far as computer vision is concerned.
Yeah, thanks for that clarification. Second point is regarding the consoles. Currently, we are dealing with big consoles occupying the operation rooms, a good amount of space, and very complex machines. So in your talk, you little bit mentioned about this. So the transforming the technology of robotics to the near to the patient. So non-console robotics. So where are we heading? So are we in a right direction that the robotics, it is going to come to the instrument handling, instrument tip and all that, so that the bigger machines which are converting from the surgeon to the patient is going to disappear soon?
Yeah, I mean, that's literally the $1 million, or I should say the $1 billion question. I personally think robotics right now, in its current form, is creating two worlds. You're creating the people that are going to have access to very expensive robots, and then you're going to create a world where people have no access to healthcare. There's 60% of the world has no access to surgeons. They have no access to endoscopy, and it's on par as a crime against humanity that we keep pushing these robots, and we're not leveling the playing field. Nonetheless, even though that's unjust, it doesn't mean it's not going to happen. Okay, so it's happening. You need access to robots. People want robots. Patients want to go to a robotic surgeon. This is why I'm so excited by smaller robots, handheld robots, by the Maestro. It's much less expensive. I think it'll have many of the same advantages, and it'll enable more surgeons to say, hey, I do robotics also. I'm a robotic surgeon. Unlike the hospital down the street that does Da Vinci, I'm going to be in constant contact with you. I'm going to be with you throughout the whole operation. So I'm very excited about this type of robotics, collaborative robots that'll enable more surgeons to have the benefits of robotics, therefore more patients to have the benefits of robotics. So I think it's very important that hospital administrators, maybe you buy one Da Vinci or one Versius for extremely complicated cases or prostate surgery or what have you, but instead of buying a second Da Vinci, maybe you buy two Maestros, or maybe you have the Vicky, the one that holds the laparoscope, and maybe you have more surgeons that are able to have some robotics during their cases.
Yeah, thank you. I invite questions from other esteemed faculty who are sitting in this panel. Yeah,
Dr.
Dr.
Andrew,
Jagdish, please.
Dr. Andrew, thank you for your lecture. I have 3 questions. One is, I've seen in Boston where the sensors are there on near the scalp, and then the instruments are being controlled. Is that a remote possibility for the robotic surgery? For example, elderly surgeons can use their knowledge to manipulate the instruments, number 1. Number 2, is there a way to economize the robots, especially in our country, like developing countries? Like, for example, miniature laparoscopic instruments, the robotic instruments, that can help in a lot with the endo wrist and all those. Is there anything going on about that? Third is there any progress in a sense to improve the sensation? For example, sensors on the tip of the fingers or the instruments which communicate with the nerves of the surgeons.
Yes, so I'm going to go backwards because I'm afraid I'm going to forget all your questions. The first one is haptics or computer haptics. And I actually have a patent on this topic, and I'm currently getting Series A funding, so I can't tell you about that. But I think haptics is very important. It's very interesting to me. And I think there's a lot of exciting things that need to be done. But again, it needs to be done by us because industry doesn't care about haptics. We have to do the research. You and your departments, you need to encourage the younger surgeons to get masters and then PhDs in artificial intelligence. And then we need to fight for this. We need to fight for money to develop haptics. So again, I'm sorry I can't talk more about that, but there is something hopefully coming. The second question, there are handheld robotic instruments. I didn't have a video that I didn't show. I do have a video from a company in Israel. It's called Handex. It's a wonderful instrument. It actually has 8 degrees of freedom. You hold it and you can have 8 degrees of freedom, not just 7 like the Da Vinci. And it's about $50,000. And again, you get all of these wonderful benefits and you get haptics, so I think pushing, it blew my mind that people haven't been talking about handheld robotics. I mean, we have the technology, it already exists. It seems like the robotic industry wants to classify the console as robotics and everything else something else. But as I've been telling you, Da Vinci isn't even really a robot. It's just a telemanipulator. So I think part of the problem is us calling Da Vinci a robot. It's not a robot. It's a telemanipulator. So I actually think using smaller robots, doing handheld robotics, taking back the definition of the power of the word robotics, I think we can actually change things. So again, this is why I encourage people to come to the journal and learn about the different definitions to understand what we're talking about. Now, your first question, I can't remember. You have to remind me.
The use of sensors in the scalp, like I've seen in Boston, where small instruments are being controlled with the thoughts of the person.
Yeah.
I mean, it's a long way to go.
I think it is a long way to go. I mean, right now with the camera being controlled, it's controlled because it's able to recognize, say, the hook, and the camera will follow the hook right now. The thought of something following my thoughts, the amount of studies that the government is going to make you do to get that approved, tells me that that is at least a decade away, if not longer.
I like these Handex instruments. I saw that in Sheba Cancer Center in Israel. I think
Yeah,
they had a hook and they had a grasper. I think that's a revolution, but it has
I also
not
think,
a launched in India.
imagine the Handex again, but imagine a robotic arm holding it. So when you let go, it stays in place. It maintains its angle. It could be a really beautiful instrument. For me, this concept is where we should have started with. It's like we skipped the step. We went from nothing to the Da Vinci. I repeat this. I assume people know this, but I know a lot of people don't, so I'll repeat it again. The Da Vinci was initially developed by the US government so that surgeons could operate on soldiers in the field. Yeah, but then they once laparoscopy came, they changed it and they tried to do it for laparoscopic. So it wasn't conceived, the spirit of it, the birth of it is off. So this is again why I plead for more surgeons to take control of this innovation.
Anyone? Yeah.
Baiju, Andrew, I wanted to ask you, you are talking about both Da Vinci and as well as CMR. And we have both both Da Vinci as well as robotic. What do you suggest me how to compare to do anything artificial intelligence, these kind of things, research? I don't know. We are doing its procedures. I don't know what to next level we can go. Can you suggest something to do this way? Both are working different way. That is.
Yeah. So that's an interesting question, because obviously I encourage you to continue with the Da Vinci. I encourage you to continue with the CMR, because I think they have their place. I don't mean, I know I'm very, very hard with them, but I don't mean to imply, I absolutely think they have their place and they're wonderful devices. I think all you can do is hope that they develop more artificially intelligent things, like they have autonomous tracking. But right now the instruments are pretty limited. They're just telemanipulators. So yeah. I have a hard time of thinking how, yeah, I'll have to get back to you on that. That's a tough problem.
Okay. In a Da Vinci, two consoles can be there for two surgeons to work on. A CMR, what happens, and the primary surgeon works on the console, and the assisting surgeons can use the laparoscopy instruments itself during the procedure, like for example, like Assure, or if you want to do harmonic, and it is not the CMR, but we can use it. Something looks a different way, but we have to do more number of cases how it can be. Particularly in developing country, we can make it more viable. And
robotics. The Da Vinci is very interesting with as far as AI is concerned. As far as training with the simulator, I think it would be interesting for you to create like a robotics course or a certificate that your residents have to obtain before they become certified to do robotics. And I think standardizing this could be very interesting, because the simulator is completely based on artificial intelligence, and it's you're going to be able to quantify people, with the efficiency of their movements. So that could be very interesting.
EMR simulation is very good, but many times it fails me also. Some testing timing, it gives slow, faster. Some president training, it looks very nice. Good.
Yeah, but that could be great. Yeah.
And I think Baiju, you can take over from.
Yeah, Dr. Kalpesh.
Yeah. Good evening, Dr. Andrews. This is Dr. Kalpesh Rani. So, one of the very interesting fields of research that was taking place about 3-4 years back was the use of augmented reality in liver resection. Now, what they were doing was that there was a computer program which would take all the information from a CT scan of a patient with, say, a liver tumor. It would create a 3D model with all the real-time vessels and the tumor, and the surgeon could actually plan out the planes of dissection and the path of dissection, avoiding all the vessels, everything pre-operatively. And the next step in that was that how to project that onto the liver actually. And if the surgeon wears gloves with sensors, then it could be like a program while he's doing the resection. Then the program keeps on telling it if it's going near the vessel and if it's in the right path of dissection or not. But then nothing further I've heard about it. So are you aware what's the latest status of this augmented reality in liver resection?
I mean, as I mentioned, the problem with augmented reality and liver resection is it gives you a preoperative image. But in surgery, things change. When you cut the liver partially, the anatomy completely changes, but you have your 3D image that was created preoperatively with the liver intact. So, they don't have the technology now for it to adapt in the operating room. That's exactly the problem. So, sorry.
Yeah, please continue. Yeah.
Yeah, no, so right now that's the problem, and that's the huge limitation. And again, if it's off by 1 or 2 millimeters, it's essentially useless to us. That's why personally I prefer using the ultrasound.
Right.
I don't have a good answer for you because I rely mainly on my understanding of the liver anatomy. But again, I think younger surgeons are going to be trained in a different way. They're going to be probably more dependent on virtual reality, preoperative planning and programming. But again, from our CT scan images, we can get 3D images. I've been using 3D reconstructions for over a decade. And your understanding of a 3D reconstruction and what you find in the operating room are sometimes two different things, as you know. So it's hard to imagine augmented reality anytime soon being able to truly keep us out of blood vessels. It's just not there yet. I don't know if you're gonna have to inject sensors. For instance, when they do the anastomosis, I mentioned the STAR robot. It does a gastrointestinal anastomosis. Before the robot can understand where to put the needle, they have to inject fluorescent dye all around the opening of the intestine on both sides so that the computer can see where it is. So maybe we're going to have to inject fluorescent dye in certain points around the liver so that the computer can start to change. But I'm not too thrilled about having to inject anything in the liver. But it's going to be a tough problem. It will be solved eventually. It's just that, again, they've been working on this for over a decade and they haven't solved it yet.
Right.
Probably one of the issues with that is the incorporation of this AI in dynamic imaging modalities like ultrasound. I think there is a big gap. We have a huge development in the AI in the CT and MR, but at the same time, interoperably, when you change the position of the liver and rotate it or manipulate it, suddenly the fixed image-based AI systems will no longer be useful in TROP. You need it in ultrasound or dynamic image systems. But because
I think, Biju, even now with the sort of advancements that are happening in computer graphics, especially in the video gaming industry, there are wearable sensors. So you can put sensors on the liver. There are sensors. You can put the sensors on the surgeon's glove, and all this data can be calculated real time in real time by the computer. And with the superimposed image of the 3D liver beforehand, I think probably the work is it's merely the gap is, I think, convergence of technology. I think all the things are not just meeting at the right place right now, but most of the technology that is required with the advancements that have taken in ICG imaging recently, all that should actually it's everything is placed. It all just needs to be brought together, I think.
And Dr. Jagdish?
Dr. Andrew, I have one request. 14 years back, there was no robo in South India, and we had to go to USA and struggle a lot and learn. So what I request you is, Amasi College, we have a lot of students, through Palanivelu sir and other people president. You can let our students, like postgraduates, to come over there, see the advances, and because the younger people you train, they'll be our future surgeons and future researchers. So I request you to coordinate with our Amasi College, with Dr. Devoshi Palanivelu sir, and allow some few students, 3 students, 4 students, every 6 months, every 4 months to come and see you. that itself will stimulate research and growth in the minds of them. If it's okay with the
Of course.
Amasi College.
Yeah, I think that can be done. We can.
Yeah, of course. My pleasure. Of course.
And the interim, this time when Jani is asked a question about superimposition of real time, I was doing laparoscopic surgery for a patient who had a hernia surgery somewhere. The screws all went into the pubic ramus, not seen, no? Laparoscopy, when seen, not known where exactly. Then we brought CT, then showing image guiding that we pierce the periosteum and the bone, then unscrew that, remove it. I think this kind of, as Johnny put in, it is way of research. I think the superimposition will have way, but we have to wait and see that how it is.
Yeah, I think superimposition, we mentioned ureters. I actually think it would work very nicely for ureters because ureters don't move a lot, so some soft tissues would work, but liver is even harder than pancreas. Pancreas doesn't move a lot. So I actually think it would be, augmented reality might work better for the pancreas, but the liver is tough because, we move that guy a lot, as you know.
Yeah, there are some questions from the audience. I will read the questions for you. Comparison to laparoscopy, where the robotic surgery stands. It's a general question. So minus the cost factor, what do you select?
Personally,
what is the basis of selection? That was the question. Yeah.
I personally prefer handheld robotics. I personally prefer to be in contact with my patient. I don't like being at a console. That's just my personal preference. However, now that I'm older, my vision isn't what it used to be. My energy isn't what it used to be. I can see the benefits of robotics, and I'm getting a new perspective as I'm getting older. I'll just be very honest. So I think robotics is going to be, I'm going to be using it more and more as I get older. Because when I use the robot, at the end of the day, I'm rested. When I do it laparoscopically, I do a Whipple. At the end of the day, I'm exhausted. So, I do think it's amazing how your perspective changes as you get older, and the robot looks a lot more appealing. That's just the honest truth that nobody mentions.
Yeah, the next question, part 2 of that question, I will summarize this way. Is there any way that you cannot learn robotics and you can be a surgeon in the next future? Is it mandatory to learn robotics?
I think it would be better to do some robotics. I don't think you need the Da Vinci, but I do think if you can get a laparoscope holder, it'll make your life better. I do think if you can get a robotic stapler, maybe I think you'll have fewer complications. So I do think there are many different definitions of what a robotic surgeon is. I think if you just get the Handex that we're talking about, I think you're a robotic surgeon. I think if you use the ligature, you're a robotic surgeon. So it breaks my heart because I see it happening, here also. It's not just a problem in India, that we're creating two castes, of surgeons, ones who have access to the robot and ones that don't. And this is really a reflection on really a sickness that is permeating society on multiple levels. So this is why I like the idea of cheaper robotics, cobots, so that we can all, on some level, be quote unquote robotic surgeries and not be forced, not have hospital systems forced to buy a robot so that they can compete with the neighbor down the street. The reality is, if you don't do robotic surgery in Europe, in America, and probably in many places in India, you are going to be, you're going to have economic problems. You're going to lose patients. So I kind of think of robotics as a necessary evil. And I think it's very dangerous to ignore robotics. in 2023. I think you have to be involved. Hopefully you can be involved with artificial intelligence. I think artificial intelligence can be done all over the place, research in it, learn about it. I don't think it's cost prohibitive, but yes, I encourage you, unfortunately, to try to learn something, to have some kind of robotics in your practice.
Okay, Andrew, in this connection, do you, it's open to robotic you recommend, or open laparoscopy to robotic? Which way you suggest? I think it is audio got checked. I think Wi-Fi some problem. Huh?
Yeah. Yes, sir. So meanwhile, while he's getting connected, one question which is basically, I think from Andhra.
Hello, I'm back.
Yeah.
Sorry,
Sir,
what was the
please repeat.
question?
Yeah.
Andrew, in this connection, when you suggested so much, open to robotic, you suggest, which is way too better?
Which is better? I mean, I don't, there's no answer to that. I think in an ideal world, open surgery, laparoscopic surgery, and robotic surgery, and you tailor to your patient. I think some patients need open, some patients, they're very obese. I think robotics might be nice. I think in today's age, you need to do all three. For me, I don't like it when I hear robotic surgeons, they go from robotic straight to open. I think that's a shame. I think you should use all three modalities. I know a lot of robotic surgeons that don't do any laparoscopy. And for the older surgeons, I understand that's okay, but I think it's a shame that we're creating now young surgeons that only do robotics, and if they have a problem, they go right to open. So I think in an ideal world, you do all three. But I also think robotics can be used during open surgery. I think we can use robotic arms to retract. I think, again, we can use the Signia stapler. So I think robotics is a much bigger, broader field than we think.
Yeah. Next question is related to the approval by the insurance and reimbursing agencies. Probably, I request Dr. Andrew to comment about this in the overall global point of view. The insurance agencies will approve this technology or not, and the Indian perspective, I requested Dr. Jagdish to comment about this. Why it is not approved in India?
Are we talking about artificial intelligence, or are we talking about robotics?
Robotics and both. Approval agencies.
Well, I mean, I think we need studies to prove that robotics is as good and has an it makes economic sense when compared to laparoscopy. I don't think we have studies that show a clear advantage to the robot. That said, I do think the robot certainly has advantages. I know it has advantages with prostate surgery, but I'm talking about in surgery that I do, liver and pancreatic surgery. Some papers are starting to say there might be an ability to preserve the spleen more with the robotic, with distal pancreatectomy or what have you. I think ultimately, or at least currently right now, part of the burden of the cost should go to the patients for robotics, because it's very hard to justify that added cost. So I think if you want robotics, you should pay for it. And, I don't have time to talk about societal issues about, who can afford what, but I do think robotics should be available, but I do think it's not unreasonable to ask people to pay more for it. I think laparoscopy, the costs are less, the difference is less intense than with robotics. So I personally am a big fan of robotics, of laparoscopic surgery. So I think that should be continued. I think there are real clear advantages, short-term, economic, to the patient and what have you. As far as artificial intelligence, again, we talked about how it's already in existence. Without the ligature, we wouldn't be able to do laparoscopy, right? I mean, we would, but it would take too long. And we wouldn't be where we are today. I think artificial intelligence is fundamental, more so than robotics. I think we need to have clean data. I think we're going to be able to solve healthcare problems more so than we can with straight robotics. And I'm talking about diagnosing things sooner, following things sooner, picking up postoperative complications sooner. Personally, I'm developing an autonomous robot that can do colonoscopy. I think because of the fact that 60% of the world has no access to a gastroenterologist, this is a crime. 1 million people a year die from colorectal cancer. So yeah, come and get it. So I think if we can start to do screening on a larger scale, if we can develop autonomously functioning robots that can do this, I think we should. You know, it was going to take us decades to train enough people to do colonoscopies on everybody. But in 2023, we could literally eliminate mortality from colorectal cancer. So AI has the potential to fill in the gaps, to help us treat more patients. So I really am more excited personally by artificial intelligence than I am by robotics.
Yeah, Dr. Jagdish, you want to
Sir,
answer for that?
in India, Arogyasri, that's a government scheme. There is no approval because I think economic frugality is more important there, and I don't think any government will give approval for the robotic surgery. And our cases, we are getting approval, sir, like low colorectal cancer, esophagus, prostate. We are getting insurance availability. I can forward the details to you and the data from IRDA where approval is possible. We are able to do under insurance.
But are you putting it as minimally invasive surgery?
No,
or
no, robotic only. Robotic. We are able to do. We can ask our Da Vinci colleague there to give the data to you, sir.
Yeah. Jagdish, this is insurance gives only a few centers. They're all access to the insurance companies. And that is why it is. It is not possible to give all the hospital if they apply for robotic. Even I have not got even one patient till now because we are not in the tract. I must be in the corporate so that I can get it. Second thing.
Yes.
And today, Taiwan, Korea, Japan, they give a laparoscopy insurance, but they don't give a robotic, and patient has to pay for the robotic instruments to do it. Today in Taiwan, last week I was there, 70% of the cases are done cancer is today laparoscopic, particularly even PD, they do it 2/3 of the cases laparoscopic, but they don't pay for robotic. And economically, even if we work out, and the way amount of people suffering, as Andrew said, colorectal or this, it is there are number of centers robotic available today. They cannot cater service to all the people who need it. That's why the insurance economic one, we have to look at longer term basis. Today, Bangalore getting it, Hyderabad is getting it, Delhi getting it, Bombay getting it, but not smaller places. However quality of work it is there, they don't scrutinize on the basis of this. That is a little difficult, it will take time.
Okay, sir.
There are no further questions. We'll just wait for 1 minute for any more questions, and then we'll hand over to Dr. Varghese.
Meanwhile, as convener, I think I should thank Dr. Andrew for elaborating so much data. And personally, I feel there's a lot more to do robotics in data analytics, personalized medicine, machine learning, predictive modeling, computer vision, and augmented reality, and as well as personalized medicine. I think a lot of things to come in the future. And personally, I feel every surgeon, young surgeon, should go and see and decide for themselves whether it is useful or not. Of course, frugality can be economic, frugality can be time related also. It is up to the surgeon's experience and his data that he should decide where to go, what to do. But exposure, at least 20% of them, 20% of their time, they should be exposed to the advanced. Otherwise, we will not be ready for the future. Yeah. And I like your statement, I'm back like Arnold Schwarzenegger in Terminator. Every time you are going and coming back, remind me of Arnold, Andrew. And I hand over to Dr. Deboshish, sir. He's our secretary of AMASI to conclude.
Thank you, Dr. Jagdish. Thank you, Professor Andrew Gums. This was really an exciting lecture. It was not only informative. It has stimulated a lot of brains among MSc and the young crowd which is watching your lecture today. I would like to tell you today that generally we transmit this information that our lecture is coming up, but today most of our MBBS students, most of our PG students are logged in to this lecture of yours, who are trying to learn many things from your lecture. This has really been exciting, and this has created interest across all the departments of our institute, and particularly the medical colleges in Delhi. I thank you again for being a part of this lecture series, which is being organized by MSc. And I take this point to thank Meryl, who has been the support to create, to facilitate these lecture series, to bring in all of us together. I also thank our founder, President Chief Sir, Dr. Palnivalu Sir, and all the MSc EC, particularly the South Zone, who has been into organizing this. Our next program is again on the Thursday, first Thursday of next month. That is on the 4th of May. We will have a lecture on bile duct injuries and the surgeon. The speaker is an eminent hepatobiliary surgeon from Delhi, Professor Adarsh Chaudhary, and it will be moderated by our ex-secretary, Dr. Abhimanyu Bosu from Calcutta, and it will be convened by Dr. Vishwarup Bose, who is the president of East Zone of MSc. Along with that, MSc is coming up with numerous programs. The first, along with this online CME, we are coming up with operative surgery online sessions, which will be transmitted live from GEM Hospital, Coimbatore and Chennai by C. Palnivalu Sir. And these will be something like, these are basically theory lectures. Those will be practical lectures, and MSc will come up with a date and will inform all its members. We are also coming up with 2-3 skill courses in the month of May, one in Srinagar, which is for the very first time happening in Srinagar, and followed it up another one in the middle of May in Mumbai. Then at the Mecca of laparoscopy, that is in Coimbatore, we have the laparoscope, the 9th edition of LaparosSurge, which is coming up from the 6th to the 8th of July. That's a program I think all of you should not miss, and you should pack your bags already for that. After that, we have our final program, the Janet of our yearly program, the MScCon, to be held in Raipur this year. We'll have it in the month of November from the 2nd to the 5th. I request all of you to become members of MSc so that all these informations are passed on to you, as Dr. Jagdish has requested Professor Gums today, that to have some people with him for some time, so that to create interest in artificial intelligence and further research in robotics, one has to become an MSc member also to avail such kind of fellowships or such kind of traveling supports any time in future, whenever it is being planned. So I request all of you to become MSc members. And thereafter, I will like to thank our president, Dr. Varghese Sir, and all the MSc EC along with the South Zone EC for this program. Thank you all. Thank you very much.
Thank you, Andrew. Thank you very much.
Thank you. Thank you.
Thanks, everybody. Have a great evening.
Thank you.
Thank you. Thank you, everybody, I think.